Hi, it's Dr. Centeno, running just a few minutes late today. So thanks so much for being here. Today we're going to talk about a super interesting topic, and that is why some new research on eye movement and memory may explain why some CCI patients get brain fog or memory issues. And kind of cutting edge research that's sort of piling on older research about how we store memories and how that might be linked into eye movement. So we're going to go down that rabbit hole today and sort of explain how all that fits together. At the same time, we're going to be obviously taking questions about that or pretty much anything else you'd like to ask. So let me start sharing my screen and we'll dive into that topic first. As usual, I'll start with a lecture, if you will, and then we'll move on to questions. So let's start with this interesting topic, why new research on memory and eye movement may explain why brain fog and memory loss happens in some CCI patients. So your neck is wired to your brain and eyes through various reflexes. And most patients, I don't think, understand this concept. And that is that normal balance and normal movement and position sense requires inputs from vision, from the vestibular system in your inner ear, and from neck proprioception. And then all of that interacts with other inputs coming in from your body. Now, in particular, there are some very important reflexes we're talking about here. And a reflex is just something that's hardwired. It doesn't require memory. It doesn't require learning. It's hardwired in. Excuse me. And that's called the cervical ocular reflex, or COR. And that means that your neck and what happens in your neck is directly jacked into your vision and vice versa. Now that makes a lot of sense, right? There's something called smooth pursuit. So for instance, if we're back in evolutionary times, let's say tens of thousands of years ago or millions of years ago, and you're trying to throw a spear at an animal that's moving from left to right across your visual field, you've got to do a lot of very complex calculations there. You've got to be able to track the animal with your eyes. That's called smooth pursuit. You have to be able to then coordinate that with what's happening in your neck, because at some point you'll have to turn your neck. And then that has to be coordinated with the rest of your body to be able to throw that spear so that when it gets to the animal, it reaches the animal. So there's an immense amount of extremely complex calculations that have to be done in real time to make that happen. And that's through this cervical ocular reflex. So very important to understand that cervical ocular reflex and the other reflexes where all these systems talk back and forth to each other. Now, the new research in particular talks about how all of that is linked together, if you will, to memory. And here they're talking about eye movements being involved in how we remember. Now, it's been known since the 60s and 70s that eye movements may play a role in memory, and that's the entire field of EMDR. EMDR has to do with retraining eye movements to help people move on from really scary type memories, let's say PTSD. So the research showed that in recalling a specific memory, we repeat the eye movements that were used in attaining that memory. So that's an interesting concept, right? Let's say if you in attaining the memory had to look that way, and then you had to look that way, and then you looked that way, in that order, 1, 2, and 3, let's say in watching something, then as you recall it in your brain, your eyes instinctively move first that way, and then they move that way, and then they move that way. So pretty freaky if you think about it, that these small eye movements are constantly occurring and they're necessary for us to remember something. So again, to keep it simple, even simpler than that. For example, if you looked left at a car crash yesterday, when you recall that memory, your eyes are going to reflexively move towards the left. And this new research really confirms why EMDR therapy, which is used basically to retrain the eyes around memories, works. Because if you disrupt that pattern, then you can kind of forget about the traumatic memories. Now, for a long time, EMDR was considered sort of voodoo. But as this field has developed, and especially now with this new paper, I suspect we'll see new interest in EMDR because the systems are a lot more complex than we first believed. Now, here's the kicker for someone who has an upper neck problem. We know, as we just talked about, that an upper neck problem can affect how the eyes move. That's that cervical ocular reflex. And this here is called the smooth pursuit neck torsion test. You're asking someone to follow something in their visual field with the head straight and then with the neck stressed. And what's interesting there is that in most CCI patients, you'll see the ability to track an object or smooth pursuit gets worse as they stress their neck. And that's because of that reflex between the upper neck and the eyes. So if that's the case, that CCI patients already have eye movement problems, and eye movement in exact detail is needed to replicate and recall memory, then you might imagine that someone with a problem in their upper neck who has an issue with moving their eyes when their head is turned, or when their upper neck is stressed because there's bad information going into the brain about what's happening in the eyes, is going to have a hard time remembering things. So again, recalling memories with your neck stress is going to impact the normal eye movements that need to be repeated accurately to be able to remember what it is you're trying to remember. And that may show up as brain fog, that may show up as memory issues. Certainly, your brain's going to be confused by that because every single time it tries to repeat those neck movements when you're remembering, and if your neck is stressed and your eyes are jerking all over the place, i.e. moving in weird ways because your upper neck is a problem, you're going to have a hard time recalling that memory. So in conclusion, getting your neck fixed and your eye movements as normal as possible may help improve brain fog and memory. And when I say eye movements as normal as possible, sometimes these things normalize on their own. And when they don't, I've generally recommended my patients see a vision therapy optometrist who can work on those sorts of issues, because I've seen some good results with that. There are also some expert physical therapists and chiropractors around the country that specialize in this type of work. So anyway, that's the conclusion. Kind of very interesting new study and really helps, I think, clarify things for a lot of patients with CCI who seem to have recall or brain fog type problems. So let's go to questions now, and we'll see what we got. Okay, got some questions, but I'm not so sure my slides showed there. So let me know if you didn't see my slides there. I may have not pressed a little button that needed to be pressed there. So let me know what you saw or didn't see. Okay, so let's go to some questions, and if so, we can repeat the slides real quick. It's been advanced by Harry Winston. Is it more common in EDS patients with CCI or all CCI patients? Is this more common? No, I think all CCI patients that I've seen have issues with, well, not all, but a good chunk have issues with brain fog and memory. So that's not all CCI patients, or I don't think it's any more common in one versus the other. Damien, good afternoon, Dr. Centeno. What do you normally do if a patient had a BMAC and 10X model B for moderate arthritis and several bone spurs in the ankle, but is experiencing more pain? Yeah, Damien, I'd go back to the doctor that did that procedure. I need to know more. What was done with the BMAC? What was done with the 10X? What were the goals of the procedure? Who did the procedure? A Regenix site, some other site, etc. Daniel, while I'm feeling the instability and have symptoms like brain fog, why is it that I'm feeling the instability and have symptoms like brain fog when my atlas is holding adjustment? Yeah, Daniel, the issue there is that the same brain fog occurs in people who have any kind of upper cervical injury, not just craniocervical instability. So at the end of the day, that's common to all people who have issues in the upper neck, not just CCI patients. So that just may mean that you have an injured joint up there that's providing bad information to the brain despite being in alignment. Cian, Eagle syndrome. I'm checking next Monday. I think my problem is I got like an object kind of feeling my left side of my throat, side of my neck. Have you seen cases where C rotation is? Cian, not clear on that question. So maybe I want to ask that one again, or is coming from the styloid. Looks like there's a second part of that. So again, from our standpoint, generally what's occurring there is upper cervical instability that is putting pressure on the vessels and nerves and structures between the C1 transverse process and the styloid. And since cutting the styloid is dramatically more invasive than doing a PICL procedure, if you've got upper cervical instability, the order to keep you safe would be PICL procedure first, surgery on the styloid second, because once we cut the styloid, we're cutting the stylohyoid ligament, which is a major stabilizing ligament, meaning there are no spare parts in the body, they don't exist, for the anterior neck. So if you've got CCI, cutting the styloid is going to make you worse, not better. And hence, better to try to fix the instability. And if that doesn't help, you can always get the styloid cut. But cutting the styloid first is a higher risk procedure. So you're skipping over a lower risk procedure to get there, which is always a bad idea. And it's a permanent change to your biomechanics of the neck, which can't be undone. It's been advanced by Carly Koppel. Does this memory issue symptom help to confirm CCI in patients with upper cervical instability? Upper cervical instability in general is CCI, so I'm not quite sure how the memory issue would help confirm that. So I'm not sure what to tell you there. Daniel, is Prolo sugar water? Yes and no. Prolotherapy is just the use of a hypertonic solution. What hypertonic means is that the solution is more concentrated than your body's normal solutions. And a common treatment in prolotherapy, one of the types of treatment, might be to use hypertonic dextrose, or usually 12.5% or 10% dextrose. Now, there are also other types of prolotherapy solutions that have nothing to do with dextrose. So dextrose is technically sugar water, but hypertonic solutions have a dramatic impact on tissues. So for example, let me give you an example that'll be easy to understand. So your body's normal chemistry is 0.9% concentration, the same concentration as seawater, because we all evolved from all of that. And at the end of the day, if I take your red blood cells from that type of solution and I were to put them in just a 0.9% concentration change in distilled water, meaning 0% concentration or 0% osmolarity there, then all of your red blood cells will pop within 10 seconds. So just a 1% change in the concentration of that solution can have a dramatic impact on tissues. So if someone's saying that Prolo is sugar water, they kind of failed basic chemistry. And that's not uncommon for doctors. They didn't really like chemistry all that much. I was a chemistry major in undergrad, so I understand all that stuff. So if you talk to a doctor that said that, they somehow barely got through basic chemistry then because they don't understand osmolarity. Phil, I have moderate stenosis at C5 on the right-hand side. I'm starting to get weakness in my right shoulder, deltoid upper arm. Will posterior PRP help with this? Usually, yes. Posterior PRP will help with that. Now, a lot of that depends on what's going on with that stenosis, central canal, foraminal, etc. But usually that helps. Damon, what is your perspective on ankle distraction arthroplasty for severe ankle osteoarthritis? An ankle replacement is a little bit different than a knee replacement. An ankle replacement is a little bit less dialed in at this juncture. Now, knee replacements have about a 4 in 10 chance of making the patient worse or no better. Ankle replacement is going to be less reliable than that because it's a newer concept that's not fully yet dialed in. Having said that, there are certainly patients who might need an ankle replacement. Connor, what causes flattening of the thoracic spine? Mine sinks in, has lost its entire curve. Yeah, what causes that is looking down at a phone all day is a huge cause in our modern society, working at computers, sitting a lot, etc. Other societies that don't sit like we do, that tend to squat instead, don't have those same types of issues that we develop. Bonnie, if you have fibrin glue patch for CSF leak, will that have an impact on effectiveness of PRP down the road? Shouldn't, Bonnie. Shouldn't have any impact. Didn't see the slides. Well, that's a bummer. I think that was my fault. I didn't press the right button. So let me know in the comments if you'd like me to show you the slides this time and do a second run at that presentation. So I apologize that that didn't work on my end. Angela, my atlas is more stable, but my left eye seems to spasm, and more so when I use my jaw a lot. Would that be the vagus nerve? Probably not the vagus nerve, Angela. That's something that would have to be looked at on exam. Anya, hydroxyternal should PICL injections ideally be done before posterior injections for spinal instability lower than C0 through C2, or can C0 to 3-2 plus lower levels be injected posteriorly first, then PICL be done later? Yeah, Anya, a lot of that depends on how severe the instability is and how convinced we are that the CCI is causing your symptoms. So the patient where we're convinced that CCI is causing symptoms, we usually start with PICL because there's nothing about the posterior injections that will get rid of that. And only about 1 in 5 patients who get posterior injections in that situation don't go on to PICL. Now, if there really isn't a lot of upper cervical instability, or there's some question about whether or not upper cervical instability or CCI is causing symptoms, then we can certainly start with posterior. And sometimes we start with posterior because patients are more comfortable doing that, and that's all good too. Are there any studies that works best for ligament tightening, Prolo PRP stem cells? Daniel, I don't think those three have ever been compared in a research setting. The few times I've seen Prolo and PRP be compared, it's usually not for that application. And PRP wins that battle, but that tends to be more for things like chronic joint pain. When it comes to just clinical experience, I always tell patients that a good example of that would be a woman with SI joint instability. Generally, for Prolo, we're looking at 6 to 8 treatments. For PRP, usually 2 to 3 treatments. And for Bone marrow concentrate, which contains stem cells, we're looking at 1 to 2 treatments. So that gives you some idea of how they work. Connor, can flattening of the thoracic spine be reversed? Yeah, Connor, you look pretty young in your picture there. So that's one you got to get on right away because, for instance, I just was out visiting some family and noticed that that family member had a severe thoracic kyphosis like this. And, at that age, the answer is no, it probably can't be reversed. The shape of the bones have changed. But at your age, or at least the age you appear on your picture, yes, it can be reversed. And you don't want to get to that point where the bones start to change shape, because once you get there, it really can't be reversed. You're going against bones that have changed shape, and that's not really going to happen, or at least it's very difficult to make it happen. Phil, does lying on your back on a gym ball, stretching thoracic and neck help with curve restoration and posture? It certainly can. I do that stretch as much as possible to open up this and try to fight the effects of gravity. Now, when it comes to curve restoration, that probably needs to be a little bit more specific than that. And I always recommend that people seek out a CBP or chiropractic biophysics trained provider to try to increase that neck curve. Stacy, outside of prolotherapy, massage has been the best thing for my neck and shoulders for relief. PT has been useless. Lifting weights supported in machines and with pulleys also help strengthen. Yeah, Stacy, that's all great. Certainly, that combo doesn't work for absolutely everybody, meaning a lot of CCI patients find that loosening those neck muscles tend to make things worse. But if it works for you, definitely continue down that road. Joe Henry Munoz, looking forward to my first PICL beginning of August. And how soon do you recommend your supplements to be taken, plus any health recommendations to obtain a better draw for injection? Yeah, I think the 3 biggest recommendations for a better draw are, number 1, a low glycemic diet. There's a book that Dr. Pitts wrote on diet. Let me see if I can find that for you. I'll put the link down there on how to get the book. Let's see here. Okay, so I'm going to put the link to Dr. Pitts's diet book in the comments. So that's one to look at. Number 2 would be based on anecdotal evidence of what we've seen. The supplement seems to help. So that's another one. And then the third one is to be as active as you feel able. Now, it can be difficult for CCI patients to do that. So that third one may or may not happen, and we recognize that. Anya, thank you. Somebody who had treatment in Colorado told me that prolotherapy may work better for instability in people with EDS than PRP. Is that correct? Anya, EDS patients are all not one disease, or hypermobile EDS patients. There are multiple different genetic variants. So, for example, my niece has got a very rare genetic variant of collagen 10. Others may have different types of genetic defects that all make them hypermobile. So I think that comment came from my niece's experience, where Prolo tended to work better than PRP for her, and bone marrow worked better than either for her. So I think that's where that comes from, but I wouldn't expect that would apply to all HEDS patients, because it's a collection of lots of different diseases that all fit under that hypermobile label and that EDS label. So someone who has, collagen X defect that causes hypermobility, and someone else who has a collagen Y defect that causes hypermobility, those are 2 completely different disease problems. that only have in common hypermobility, hence they're thrown into the HEDS box. So one may respond much better to PRP than the other. Sian, when I'm sleeping on my neck, it feels like I'm choking. I sleep on my back. In an upright position, it feels like I can feel oxygen going into the left side. Is that typical symptoms of Eagle syndrome? Not usually, no. So that wouldn't be typical with an Eagle syndrome patient that I've seen, at least. Phil, can weight training with moderate to heavy weights cause CCI, or is beneficial for inhibiting it? I've not seen weight training cause CCI unless you're like an hypermobile EDS patient. But if you've got otherwise normal ligaments, then no, I don't think that's something that can cause it. Now, I have seen weight training accidents cause it. So, for instance, I've got one guy who was hanging upside down with some weights, doing sit-ups, and fell onto his head. That's a good example. Or I've seen several people who have put tremendous amount of weight on their head trying to strengthen their neck, and then heard a pop or a grinding sensation, and then were later diagnosed with CCI. So I think it comes more from the unusual amounts of weight or neck traumas that can happen, but not with routine weightlifting. If all things being equal, all the ligaments are fine. Lynn, do you ever do 82M treatments for knees, severe osteoarthritis, meniscus tears, and probably ACL tear? Yes, we use A2M. A2M, this is probably a good subject to bring up because A2M is alpha-2 macroglobulin. And all A2M treatments is a molecular filter where you've filtered out the bigger molecules in the plasma. And one of those is A2M. So it concentrates A2M. A2M is a inflammatory inhibitor. So it could be considered a breakdown inhibitor. And as such, it can be helpful when combined, in our experience, with PRP in patients that have knee osteoarthritis. Now, when it comes to severe osteoarthritis, PRP and A2M tend to underperform, and bone marrow concentrate tends to do better than either one of those. So generally, those patients would likely be moved into more of a bone marrow concentrate procedure based on the existing research. Damien, ankle distraction arthroplasty is an innovative procedure. Okay, looks like you copy pasted something. Distraction arthroplasty is not going to reverse the effects of severe arthritis in a joint. I think what you're referring to would be, let's say let's take a knee because it's an easier example, I think, to understand. So in a knee, if someone has too much weight on their lateral compartment, there's a number of different things that can be done, including a high tibial osteotomy. You could also try distraction arthroplasty, but only if there was a mild cartilage damage would you expect any of that to work. If there was severe knee arthritis, or in this case, severe ankle arthritis, distraction arthroplasty is not going to work to help that person in any meaningful way. Connor, I have CCI and AI. My thoracic flattening came after developing that. I noticed T2 to C7 area very humped, but then down from there it is flattened out. How do you straighten out? Yeah, so Connor, I think the first thing might be to do, again, since you're young, is to find a local chiropractic biophysics specialist. And I'll put the website down here in the comments. Idealspine.com is where you would go. I just put that in the comments. And you can find a local chiropractic biophysics provider who can help you try to restore all the curves, including that thoracic one. Phil, does loss of lordosis curve, straight military neck, or reverse curve place more tension? Yes, it does. We believe, Phil, that it does. So if you've got a loss of curvature, we're going to recommend at some point that you see someone to deal with that loss of curvature. And now for a lot of CCI patients, they probably can't tolerate that. right up front, but some can. So what I always tell my CCI patients is if you roll up a small hand towel and you put it behind your neck to increase the curve, and you lay down on it, and you may have to mess with the size of the towel or the size of the roll. What will happen is one of two things, right? Either it's going to feel good or have little effect, or it's going to really flare things up. If it feels good or it has no effect, then you really might want to consider that idealspine.com website to try to find a curve restoration expert near you. Now, if it totally flares things up, you're just not ready to do that yet. And the CCI has to be treated before the curve restoration would be effective or really be permitted. Connor, could this be related to very tight scalenes? Absolutely. That can definitely cause tightness in the scalenes. Stacy, Phil Jeffries, I do a body pump with a plate in front of me instead of my barbell on my shoulders. All weightlifting supports everything above, use tighter, lighter weights and more reps. Yeah, Stacy, I don't know that most CCI patients would be able to tolerate that kind of stuff. So Phil, you may want to be careful with that. That's just my experience. So yeah, if they find that the stylo is compressing my jugular vein, should I go agree with the surgery for Eagle? Cian, I think I've answered this question a bunch of different times. So surgery for Eagle syndrome is never a first-line treatment. It's an end-of-the-road treatment because it would destroy the normal stability of your upper neck. Now, that may need to happen, but I think I've given you this link already, but if I haven't, I will put it down below. So I wrote a whole article on this. And again, you may need to go ahead and get surgery for Eagle syndrome. I don't know. But if you've got CCI, it's not a first line treatment. It's a last end of the line treatment before you might consider fusion for your CCI. So you would treat the CCI through injection first. And if that didn't work, then you would consider getting the styloid cut. But you're doing it backwards if you get the surgery first, and you're doing something that's completely irreversible, meaning that there is no way to regain your anterior neck stability once you've had a styloidectomy done. That just is what it is. That ship has sailed, and that's never going to be the same as long as you live. Anya, thank you. Do you know Dr. Agnes Stogisia in Hungary? She performs injections for spinal instability. You recommend having treatment with her. I don't know who the heck that is. I can try to look that up, but I have no idea who that is. Never heard of her. I will say this, that normally Europe, regrettably, outside of the major centers like London, has very few spinal interventionalists that are trained in X-ray guided procedures. So let me see if I can figure out who this is. So I think to do the simple injections for neck stability in the back of the neck, so that would be either the C2 through C7 facet joints or the supraspinous interspinous ligament. She looks certainly qualified to do that. When it comes to upper cervical spine 01, 1, 2, I doubt there's anyone in Europe that's done that more than 100 or 200 times. It's probably just the animal probably doesn't exist. And I think the guys in London who now do a lot of upper cervical facet injections for our European patients would be better trained to do that, just based on the amount of procedures that they've now completed and done at 01 and 1, 2. When it comes to something like PICL, neither of those are going to be able to help you. So that would have to be done here. Surely curve correction won't do a thing if ligaments are damaged. It's going to make it worse. No, not necessarily. Now, if we're talking about upper cervical ligaments, then it will take the weight off of those ligaments. Now, I would agree that most of the time that's not going to do much long term, meaning that ship has sailed with regard to the ligaments being able to heal themselves. But taking the weight off those ligaments would be a good thing. It's certainly a net positive, not a net negative. Med Center said I have minor loss of cervical lordosis. Is that a minor ligament issue? I was going to go to Ian Smith, chiropractor in England. He's got a CBTC scanner and he can do digital X-ray too. Well, certainly, I'm not quite sure what the question is there. If you've got a minor loss of cervical lordosis, that's great. Then I think that means less work to do. And you might want to see if you can tolerate curve restoration to see if that kind of thing can help you. Phil, what do you think of the diffusion MRI technique for analyzing health in the spinal cord? I think that's a solid technique. There's probably a lot more incomplete spinal cord injury out there in the traumatic neck population based on some studies done by Elliott et al. Out of Northwestern. And then we recognize. So there's, I think, a lot of people who do have incomplete spinal cord injuries due to whiplash type trauma that have had pain for years and years and years. And I think diffusion tensor imaging for the spinal cord is helpful, as are other kind of tractography studies for the health of the spinal cord, because I think some people are injuring their spinal cord and that's causing lots and lots of long-term problems. But we haven't had the technology until recently to take a look at that. And that type of technology is not in wide use. So a lot of those people get undiagnosed. Okay, so we're at 1:41 my time. I do have a hard stop at 2. Other questions I can answer here at all? Kevin, does getting another unrelated procedure or surgery a month out from PICL affect the efficacy of PICL? I probably need to know more about what kind of surgery you're talking about in order to answer that question. Cian, is the Med Center accurate and diagnostic because my symptoms are likely bad and they say there's a minor loss? So Cian, I'm not quite sure what the question is here. So are they good at making diagnoses of CCI? I think they're the best in Europe I've seen to date at making diagnoses of CCI. I think they really have a great imaging technique. Now, as I talked about before, though, the number one way to diagnose CCI, meaning the most sensitive in my experience, is with a digital motion X-ray. Then a stand-up MRI like they would do at Med Center in London. And then the least likely to get to the diagnosis is a static neck MRI, where you're lying face up in a tube, or supine neck MRI. So if you've got CCI and they're saying it's mild, again, mildness of structural doesn't relate to symptoms. Those two things are not linked. So CCI can cause lots of symptoms, even if it's mild. And we've got patients with severe CCI who don't have that many symptoms. They're very functional. So there isn't some sort of magic link between the severity of the structural changes and the severity of the symptoms, based on my experience. Damien. Yes, Damien, I am, but that's going to be phasing out over the next couple of years. So basically, focusing more and more of my practice on craniocervical instability patients. But yes, I still do see other patients. That'll probably still be the case for the next few years. And we'll have to see how all of that goes. But currently, that's the direction of things. Tooth extraction. Yeah, I would be a little concerned about that. I think maybe get the tooth extraction before you have the PICL, or wait till month 3 or 4, because extracting a tooth take some elbow grease. And I hate to put it that way, but that's very, very true, meaning that you can't get a tooth out of a mouth or a jaw without pulling a tremendous amount of force. And obviously that could impact the upper neck. So I think I'd separate those two out. When you'll be retiring from seeing and treating patients? You know, Damien, that's a great question. I don't have the answer for that right now. I can tell you that the current game plan, and obviously things are always open to change in this crazy world of ours these days, is for me in September to start taking 2 6-week periods off per year. So that'll likely be, as it gets into more of a thing, it'll be a little bit different this year. But that'll likely be September 1st through October 15th and May 1st through June 15th. Now, having said that, I still will do telemedicines during that time. So I'll be off, and the only thing I'll be doing clinically is seeing patients virtually during that time. So even that's not a complete shutdown of me seeing patients. I'll still be seeing patients during that time. Now, how that evolves over the next 3 or 5 years is a good question. We'll have to see how that goes. And but I think the overall goal would be to stop seeing patients sometime in the next 5 to 10 years. But I don't know that that's going to happen either. Again, you know, who would have predicted COVID-19 back in 2019? We were all sitting here as if everything was normal, and then our world got turned upside down. So you just never know. Or as they say in opera, it ain't over till the fat lady sings. Levon, what are your thoughts on ICP to check intracranial pressure, and what would be the primary indications to do so? Yeah, I mean, so in order to actually check, and I have a lot of patients that are very confused by this. They get a spinal tap and they check the pressure in the lumbar spine. That's not enough to diagnose intracranial hypertension. In fact, it's not even suggestive of intracranial hypertension. You would need to float a catheter and measure the intracranial hypertension at a specific level in order to make that diagnosis. And so I have had some patients that have had that done. Most of the places these patients are going aren't sophisticated enough to feel comfortable with that procedure. Hence, they usually don't get it done correctly. So I want to make sure we're not talking about checking intracranial pressure from a lumbar site with just a standard spinal tap. We're talking about floating a catheter. Anya, sorry I can't find the guide to upright x-ray that you talked about on your last live stream. Can you please tell me where to find it? Sure, Carol can help you with that. I think we've got our social media person watching here today, so she can help you find that. Maybe she can put it in the comments. Do you know Dr. Ian Smith, chiropractor in England? Algocels know him. You know, I only know of him. I don't know him personally, never met him personally. Seems like someone who's definitely more astute on the CCI front. So I think seeing him is a good idea. So no issues with that concept. I think that the biggest issue I have with the concepts that we talked about today, again, is getting your stylohyoid ligament cut, because that's not a first line or a second line or a third line treatment. That's an end of the road treatment that's irreversible. So as I always tell patients, please don't do irreversible things until you've tried treatments that don't irreversibly alter your body's biomechanics. Anya, what do you think of ozone gas injections? Yeah, so Anya, ozone gas injections aren't permitted in the United States because there's never been an ozone generator that's 510K approved. So we've stayed away from them. Now, I know they are used in Europe, and depending on the application, they seem like they can have some efficacy. So I think it's certainly worth considering. You know, I don't think it's magic, but certainly worth considering for things like ligament problems. As far as PRP and comparing it to PRP, the problem there is PRP isn't one product. It's about 15 different products that are currently being used. So the question would be in comparison to what type of PRP, meaning leukocyte poor, leukocyte rich, is it the right concentration, or did they buy a silly little device from some Chinese guy selling a PRP kit? Regrettably, a lot of the literature that compares things to PRP, they used stuff that doesn't meet the definition of PRP. So PRP, as it exists today, is not one product, but about 15 different ones. Okay. Any other questions, guys, I can answer? So I've got another 5 minutes or so, 5-6 minutes to answer questions here. Okay, so let's start wrapping up and talking about what we talked about today. And that is that some new research now further confirms the idea that when you remember something, you also encode the eye movements that happened when you saw it. And recalling that thing out of your brain requires you to replicate those exact eye movements in order to remember it. And we know that CCI patients and patients with other upper cervical problems have a hard time with eye movements, especially when they've got bad information coming in from the upper neck. So that could certainly explain why many have brain fog or difficulties remembering. So thanks so much for watching today. I really appreciate your time. I think I will be here on Friday doing the same thing, and we'll have a new topic at that time. So have a wonderful week, and great to see everybody.